Thank you, Terry. And thank you, everyone, for being here to indulge me talking about really my favorite subject, which is drugs. It's been my whole career. So what the outline for the discussion today is, we'll do a little discussion about cost drivers in private drug plans, what some of the challenges are in how we manage cost, and then what's the outlook for the future. What are some of the things we're seeing? Pharmacogenetics, medical cannabis. We've had some changes in Ontario with OHIP Plus, and I'll speak to that for a moment. And then national pharmacare is something that may be on the horizon. So first, looking at some of the challenges for private drug plans is really managing the introduction of very, very expensive new drugs. This chart comes from the Patented Medicine Prices Review Board, and it's a government agency. One of the things that they do is they provide drug trends, and they used to do it only on government drug plans, but they now have been able to give us this data on private drug plans in Canada. So this is really all of the insurance companies, or the majority of the insurance companies' data collectively summed, and then providing us with some information about what's really going on with employer-sponsored drug plans. And so looking specifically at high-cost drugs, that's really the big challenge that employers are dealing with in terms of costs. It's pooling rates that tend to be really driving the overall rates. Those expensive drugs, there are more and more of them on the market, and more people taking them. What this chart is showing us is that in 2005, there were 23 drugs on the market that cost more than $10,000 per person per year. And those 23 drugs represented 6% of all the money that employers spent on drugs in 2005. Fast forward to the end of 2017, there are 163 drugs on the market that cost more than $10,000 per person per year. And those 163 drugs represent 26% of total drug spending. So a huge increase in the number of drugs that are very, very expensive, and that is what's driving pooling rates. Now, one of the things you don't really see here is what we've really noticed in the last 3 or 4 years is some really expensive drugs hitting the market. This chart is looking at 10 to 20,000, 20 to 50,000, and over 50,000. But what I want to tell you is it makes it look like, oh, well, 50,000 is sort of the ceiling. No, we saw a drug come out last year that's $2.5 million as a recurring drug claim. Many of these new drugs, particularly in the last few years, are in the 100,000, 500,000, even $1 million a year kind of price range. And so, you know, the $10,000 to $20,000 a year drugs, we're not seeing as many of those anymore. Really seeing extremely high cost drugs entering plans. And then we're not only seeing a lot of new high cost drugs, we're seeing an increase in the number of people who are taking a high cost drug. So this, again, going back to 2005, looking at out of every 100,000 Canadians, how many took a drug that cost over $10,000 a year? And in 2005, it was 263 people. Fast forward to 2017, it's now 785 people out of every 100,000 that needs a drug that costs over $10,000 a year. And those 785 people represent 27% of total private sector drug spending. So tiny number of people, big amount of cost. And so you're probably as employers here, all looking at your renewals every year and seeing that the pooling rates are really what's driving the increases. And that's what's going on here. This is why. So this is the challenge that we're struggled with trying to manage. Further, now this is looking at a little bit of different data. This comes from TELUS, and TELUS is the PayDirect drug card provider for Great-West Life and for Sun Life and for some of other smaller carriers. So it's another good snapshot of the private sector. And so they're just showing what is the amount of money that we're spending, or the percentage of our dollars on high-cost drugs. It's gone from 11% in 2008 to 29% in 2018. and from half of 1% of the number of people up to just over 1%, so doubling the number of people. But this really shows you 1% of people are about 30% of cost. And then it does vary quite a bit by region. Ontario is sort of in the norm, but as we get into other provinces, we see big differences well, just very big differences by province. I won't spend a lot of time talking about that. Now, looking at some of the new drugs that are coming out on the market. This is really frightening when we look at these costs. So this chart is really, these are all basically new cancer drugs. And you'll see a lot of them are oral pills. What that means is you're going to take those cancer medications at home and not in the hospital. And so that means your private drug plan is going to pick up the costs. So $520,000 a year, $395,000, $266,000, $197,000. You can see the immense amount of cost to have one of these new cancer drugs. And of course, if you're a cancer patient, how many of us could afford this without insurance? You know, we really need our drug plans. In order to be sustainable into the future, we've got to be able to afford the drugs that people couldn't afford on their own. And that means managing things perhaps a little bit differently in the future than what we've done in the past, so that we can continue to afford these things. Now, some more new drugs. These are not so much in the cancer area, but even looking at migraine headache drugs, which normally today cost a few $100s a year, maybe at most $1,000 a year. We now have a new biologic migraine medication coming out at $6,400 annually. And even that's not so bad, $6,400, but there's a large number of people who suffer from migraines. So we've got to make sure that we only give people access to a $6,400 migraine drug if an $800 migraine drug won't work. We've got to ensure that you try the less expensive drugs first and graduate up to the more expensive drugs, just to make sure we can manage cost. Because doctors will prescribe the newest drugs first, and I'll talk about why that is. So dry eyes, $8,700. You know, the alternative is an over-the-counter prescription that Jennifer Aniston is selling on the television, you know? So that essentially doesn't cost your drug plan anything, and now all of a sudden $8,700 is a new medication to treat dry eyes. Asthma, $48,000. Rare blood disorder, $600,000. It just goes on and on and on. The massive introduction of very, very expensive drugs. So what prescription drug plans have traditionally always done, and many of you working in HR have even probably looked at the contract language, and the contract language has really been based on prescription by law, is what we call it. And it usually reads something to the effect of, if a drug legally requires a prescription and has been approved by Health Canada and has been assigned a DIN or a drug identification number, it's automatically added to the drug plan. And so other than, the only caveat to that might be kind of lifestyle drugs. So some plans might not add smoking cessation drugs or fertility drugs or things that are considered more lifestyle. But other than that, we've always just added everything. New cancer drug, new blood pressure drug, new cholesterol, they get added automatically. And the reality is that in today's world, it's no longer affordable, sustainable, or even practical to do that anymore. And the reason is that Health Canada approves drugs based on two things. Is it safe? Does it work better than nothing? A placebo. They don't compare new drugs to old drugs. And it's not part of what they need to do, right? They need to make sure that the drugs on the marketplace are safe and that they do what they say they're going to do. They say they're going to lower your cholesterol, they have to lower your cholesterol. But they don't have to lower your cholesterol better than a different drug. So tying coverage to your drug plans based only on Health Canada doesn't make any sense. Particularly when we do know that there are government agencies that do compare old drugs to new drugs. There's an agency I mentioned before called the Patented Medicine Prices Review Board, the PMPRB. They do evaluate all new drugs, all new patented medicines, and they put them into categories when they compare them to existing treatments. And so there are 4 categories. The first one is breakthrough treatment. That new drug is so much better than anything else we've got, it's considered a breakthrough. The second category is substantial improvement. It's a lot better than any other drug we have on the market to treat that condition. The third category is moderate improvement. You know, maybe there's a few fewer side effects. The fourth category, little or no improvement over the existing drugs that are already available to treat the condition. I kind of make a joke of it and say it's, you know, it's a new birth control pill. If it doesn't get you less pregnant, should we automatically add it if it comes at a much higher cost? So now I have a question for the audience. Does anyone have a guess of what percentage of all the drugs approved by Health Canada since 2010 are in the fourth category? Little or no improvement over the existing drugs to treat the condition. Anybody want to guess? 60? 82%. 82% of all the drugs approved by Health Canada offer little or no improvement over the existing drugs that are already available. And 73% of all the money we spend on drugs in Canada is on one of those fourth category drugs. You know, that's where all the sales activity is, in the little or no improvement category. That's where when you watch TV at night and you see all those ads coming, it's because they're all the same. One antidepressant doesn't work better than the next antidepressant. One cholesterol pill doesn't work better than the next cholesterol pill. One rheumatoid arthritis drug doesn't work better than the next rheumatoid arthritis drug, or generally speaking. Some drugs are breakthroughs, some drugs offer improvements, but they're more like 2% and 4%. 20% or so might have a little bit of an improvement over existing treatments, but the vast majority do not. That's also where all the sales reps are in the doctor's office, really convincing the doctor, prescribe my drug, prescribe my drug. That's where the efforts have to go, because they're all the same. And they want the doctor to prescribe their drug over their competitor's drug. So there's a lot of activity in the sales department of the pharma companies on those slight or no improvement drugs. They have to put less efforts into the sales of breakthrough drugs and, substantial improvement drugs. It's really the aggressive marketing at that fourth category that is driving the prescribing of these new drugs. Because you better believe when a new drug comes out, it gets prescribed. And why? Why are doctors prescribing all the new drugs instead of the older drugs, even though they do know the older drugs typically work just as well? And the reason for that is we probably all know the answer because we've all experienced this in the doctor's office. Does anybody know what question the doctors always ask you just before they write a prescription? Do you have insurance? Do you have a plan? What they're really asking is, do you care how much this costs? And what do we answer? I have insurance. I don't care how much it costs. So the doctor goes, okay, taking cost out of the equation. I'm not even going to consider that as a factor. Instead, I'm going to look at these other factors. I'm going to look at what my peers are prescribing, the research that I'm reading, the advertising that I'm seeing, the free samples and the sales reps that are in my office, and my own experience, what my patients are telling me. But I'm really not going to take cost into account. And so the new drug comes out, the sales reps have been around, they've gone to the continuing education events, they've maybe got a pen in their hand with the name of the new drug, and you come in and they feel you have high blood pressure or high cholesterol or depression or whatever the case may be, and it's the newest drug that is the one that gets prescribed. And so we are paying for a lot of new drugs that don't have a lot of value over the substantially less expensive drugs that are already available on the marketplace. And so as carriers, we have to change the way we do things. We can't tie coverage directly to Health Canada anymore, given that we know what's going on in the marketplace. And so we've made changes. And so one of the big changes we've made is around generic drugs, and hopefully most of your plans have also made those changes. There are different ways to administer generic substitution in a plan. And so we're really being much more aggressive with ensuring that plan members take the generic drug wherever they possibly can. So just to define the generic and brand drugs, there are two different kinds of brand name drugs. The first is a single source brand. That's a brand name drug that has a patent. So for 20 years, a brand drug has a patent. There's no other source of that medication. The single source is the originator drug. But after the patent has expired, after 20 years, then that patent, a generic drug company can come onto the market. So the brand is still available, but there is a generic available. So it's called a multi-source brand now, because multiple sources of that medication are available. And then there are the generic drugs themselves that are copies of those brand name drugs once the patent has expired. So when we talk about generic substitution in plans, we're only talking about multi-source brands. If you have a generic substitution plan and your drug is under patent and there is no generic, it doesn't affect your coverage. But if you have a prescription for a multi-source brand drug and there is a generic available, the insurance company is likely to pay only up to the price of the generic, depending on the plan design that's in place. And the reason for that is the cost difference. That's really the big difference between brand and generic drugs, is the cost. Generic drugs are legislated in Canada, the majority of them now, to be 10% of the price of the brand. If the brand is $100, the generic must be $10. So the cost savings are absolutely enormous around generic substitution. So you really want to make sure that you have the right design in your drug plan around generics. There's sort of two ways to go. The first is called regular generic substitution. And that says, I'll pay up to the price of the generic unless the doctor writes do not substitute on the prescription. That's sort of the old way of doing things. In today's world, we now have more of a mandatory generic substitution approach, and that says we will only pay up to the price of the generic unless the doctor tells us why they've written no substitution. You know, when I was a sales rep in the pharmaceutical industry, it was important to me to get the doctors to write no substitution on all the prescriptions so that I could meet my sales quota. Didn't have anything to do with a patient having an allergy or a reaction. So, you know, in today's world, we need to ensure that our plans are only paying for a brand name drug where the doctor has specified on a form that the person has a medical issue with a particular ingredient in the drug. Otherwise, your plan will be paying for a lot of brand name drugs at $100 instead of generics at $10 when there really is no medical reason to do so. And this data really is showing us that. You know, a cost of a claim if you have a plan with no generic substitution at all, $412. If you have regular generic substitution where you allow no sub, $135. And if you don't, if you say no, we only are going to pay if there's a medical reason, it's down to $27. So you can see this really demonstrates that no sub will be written without a medical reason in a substantial amount of the cases, and that's why you really need to have that mandatory generic substitution approach that says you got to prove to me that you have an allergy or a reason that you need to take a particular medication. So that's talking about some of the challenges that we have in managing drug plans. Now I want to look at some of the potential opportunities. Maybe OHIP Plus is no longer an opportunity, it's now a challenge, but we'll talk about that. So first of all, I'm really excited about pharmacogenetics. I think that this holds great promise for the future. So what is it? It's laboratory testing of a person's DNA to determine gene variations that will predict how you will respond to medications. So basically, at the end of the day, it's a DNA sample that tells a physician whether or not a drug is going to work for you before you even take it. Because we all have different ways that we metabolize in our liver. We metabolize things in our liver. Some people are fast metabolizers and some people are slow metabolizers. Some people are ultra fast or ultra slow, and that really affects how a medication is going to work for you. So as an example, if you, let's say you have a 10 milligram pill and you swallow that pill, and the way it should work, and I'm kind of making up some numbers, but you know, let's say in 5 minutes, 1 milligram is going to be in your bloodstream, and then in 10 minutes, 2 milligrams will be in your bloodstream. And your blood uptakes the medication until you reach your 10 milligram dose, And then you start to eliminate the medication, and then you go down to 9 milligrams and 8 milligrams and down to till you get down to 0 milligrams, and then you take another pill. And so that's how it is supposed to work. But if you're an ultra-fast metabolizer, you're sucking up that medication so fast and you're spitting it out before you ever get to 10 milligrams. You actually never got the dose you were supposed to get. If you're a slow metabolizer, you're really uptaking it very slowly and you're not spitting it out quickly, and so you're actually getting a much bigger dose than you're supposed to get. And so pharmacogenetics will help doctors understand what your liver enzymes are, how they metabolize different drugs. There's many different enzymes in your liver, and different drugs trigger different enzymes. So this is a really effective way at helping to understand how you're going to react to a medication before you've ever taken it. So this is really promising. And so we're doing a pilot project on it right now with a company called Genuine. Their test is called PillCheck. And we're using these pharmacogenetic tests on people that are on disability to see if having the test changes what they're prescribed and then changes their health outcome. So one of the things I want to say, though, is that these tests are kind of complicated. You know, this is still in its infancy, this technology, and the average physician probably doesn't really know even how to read the tests yet. That's why we're doing the pilot project now, because part of the pilot is having a clinical pharmacist work with the physician so that they understand how to interpret and then prescribe. Because this is what the actual test results look like. They're kind of technical. I don't know if you can all see this very well, but you know, one result might be that this person is an ultra-fast metabolizer at CYP2C19. Do you think the average doctor would know what C12CP19 is? Maybe not. You know, so we have a ways to go before this type of testing can be used commonplace. But we know in the right environments that it really holds a lot of promise to make sure that people are actually taking drugs that are working effectively for them and that they're metabolizing appropriately. Now, we also know that 90% of the population has at least one genetic variation that will impact the way that they metabolize drugs. So really, you know, any one of us could be a good candidate for these tests. Some conditions are more likely than others to produce results. Depression is one area in particular where people really have, many people who are taking antidepressants are taking many different medications before they find the one that works for them. And there's a lot of suffering that happens in that time period. So, you know, there's real promise with pharmacogenetic testing, more so for some conditions like depression. Cancer is another one where we actually have seen pharmacogenetic testing for a long time in cancer. It's part of what Health Canada does. In some cancer medications, you actually are legally required to have a genetic test to see if your genes match with that type of a drug, and that's when it would be dispensed for you. So we've got some use of, you know, pharmacogenetic testing, but I think it really in the future will become much more commonplace and a real opportunity to get people on the right drugs. And what do the plan members think? Some of you might be familiar with the Sanofi Healthcare Survey that's done every year, 20 years now in a row, measuring what plan members think of their benefits. And one of the questions in 2017 was about pharmacogenetic testing. You know, if an insurance company wrote you a letter and said, hey, would you be interested in taking a pharmacogenetic test based on your conditions? 67% of people said yes. And in fact, if you're on 3 or more medications, 76% of people said yes. So we know that there is quite a bit of interest in plan members of getting access to these tests. So now we'll talk about medical cannabis for a moment. You know, we've just seen really late last year and early this year the introduction of medical cannabis on the majority of insurance companies' group plans. It's an optional benefit, so plan sponsors can choose to add the coverage if they want. Now, we're being very cautious. This is Great-West Life, but I believe most of the carriers are similar in their approach, in that there's really only a small number of conditions for which medical cannabis is proven to be effective. And so we would limit coverage to only these 4 conditions. So spasticity or neuropathic pain associated with multiple sclerosis, chemotherapy-induced nausea and vomiting or neuropathic pain associated with cancer, anorexia or neuropathic pain associated with HIV and AIDS, or symptoms associated with palliative care. If you're terminally ill, then there's evidence that it could be effective for you. But you know, you do hear a lot about it working for all kinds of other things, anxiety and glaucoma, and the reality is there's not evidence of anything beyond these conditions yet. Now, there will be more evidence as time goes forward. Now that it's legalized, there's a much greater ability to do research, and we'll probably see research coming out that shows it is effective for more conditions. But that is what concerns me a little bit, because if you were to, you know, ask for a quote from your insurance company to cover it for just these 4 conditions, it wouldn't be particularly expensive. But what if in 2 years it's found out to be effective for anxiety? How many of us have anxiety? I mean, I drive home on the 401 in traffic every day. I have anxiety every single day. And, you know, so what if I went to my doctor and said, sometime, you know, at my annual physical, how you feeling? Well, sometimes I have some anxiety. Oh, well, you know what? There's cannabis. That's something I could prescribe to you. It might not even have been something I'd have thought about taking, but now my doctor's asking me. It's, you know, legit, right? Now, how many people might be taking it, and what might the cost implications be? And while it might be proven to be more effective for anxiety in the future, will it be more effective than the existing treatments we already have on the market? You know, Valium is $0.25 penny a pill. Cannabis is $5,000 to $10,000 to $20,000 a year. So, you know, just like what I've been speaking about, evaluating how well something works compared to other treatments already available, we have to do that with cannabis as well, and ensure that if we're paying for it, that it's appropriate and that there aren't other treatments that will be as effective at a lower cost. We are putting limits in place. 1,000, 2,500, and 5,000 are the options that a plan sponsor can choose in terms of maximums. And as I've mentioned, you know, the evidence is going to grow, and as the evidence grows, we will evaluate it and then determine if it makes sense to add coverage for more conditions. Prior authorization is definitely required, so it's not something that you just submit a claim and it gets paid. There will be controlled distribution through preferred network of suppliers as well, because one of the challenges with marijuana is it's typically prescribed by the weight. A gram, you need so many grams, or so, you know. But the problem is that a gram from this supplier and a gram from that supplier both weigh the same, but what's the dose? How much THC, how much CBD, how much stuff is in it? Could be really a different thing just by gram. It's kind of like, you know, the 10 milligram pill weighs as much as the 100 milligram pill, but they're very different in their dose. And so it's really important as carriers that we know what it is you're getting. And so that's why most carriers are going to use some sort of a supplier network. Great West Life and Manulife as well have chosen Shoppers Drug Mart. And so there's going to be like case manager pharmacists that are working with members to ensure that they've got the right diagnosis and that they're choosing the right strain and the right dose that's going to work for them. Medical cannabis is not available in retail pharmacies yet, but we expect that it will be at some point. And so we are also putting coverage right on the drug card. And that way you'll, as plan sponsors, be able to get good reporting as well. You know, it's really going to be important if you do add it to be able to report on what is the use, what is the cost, so that you can budget and anticipate it. Oh, just before I leave that, because I think to be honest with you, it's going to be very expensive to cover. You know, I spent a number of years as a benefits consultant, so I can't help but give advice. And if I were an advisor right now, my advice would be hold off. Don't cover it yet. You know, 5 years from now, it could be a very different world. There could be a lot more medical conditions. There could be pressure on those limits. You know, if your drug plan covers 80% of Remicade, why are you covering $1,000 of cannabis when that might be representing 10% of the the cost of the treatment, you know. So I think there's going to be a lot of changes happening, evolving around the benefits world in cannabis over the next several years, and my advice would be just hold off. Don't be too fast to cover it. You know, we have a little bit of experience. Veteran Affairs Canada added cannabis in 2013-14. They did have some quantity limits, but they were fairly high maximums. And so the first year they saw $400,000 in claims. The third year it was $20 million in claims at an average of almost $13,000 per claimant per year. So we really have to ensure we're managing this effectively, that we don't see runaway costs. And so, you know, we're going to do the best that we can as carriers to ensure that if we are covering it, that it really is medically appropriate. Now let's talk about OHIP Plus for a moment. Some of you may recall back on January 1st of 2018, the OHIP Plus program was introduced in Ontario, and that meant that the government was now picking up all of the, not all of the medication costs, but a large majority of the medication costs for patients in Ontario under the age of 25. So that was a great savings to private sponsored drug plans, right? No more paying for people under the age of 25. 6 months later, they announced, well, we're changing that now. We're going to continue to provide coverage for people under the age of 25, but only if they don't have access to a private drug plan. If they have access to a private drug plan, we will no longer be funding their prescription. So that was announced on June 30th of 2018, but didn't actually take effect until April 1 of 2019. And part of the reason is that they had to figure out, how do we know who has a private drug plan? What is a private drug plan? What is what does that mean, private drug plan? So they've now come up with a definition of what a private drug plan is, and that is any type of plan, program, or account which could contribute to the cost of any drug product, regardless of whether the private insurance plan covers that particular drug, the child or youth or person captured under the plan is required to pay a copay, deductible, or premium, or whether the child or youth has reached an annual maximum under the plan. So, you know, they've defined it this way because they don't want employers to say, oh, I'll exclude any drug that's on the government formulary, and then the plan member would be covered by OHIP Plus. You can't do that. If you cover any drug at all, you have to cover sort of all drugs kind of thing. So there's not really going to be a way to avoid, if you do have drug plans, to avoid picking up the cost of the people that are 25 and under again. So you saved a lot of money for about a year and a half, and it's going to come back to you. This is some of the data that we have. So prior to the implementation of OHIP Plus, Ontario employers spent $244 million on drugs for people under the age of 25. OHIP Plus came in, and that dropped down to $121 million, so almost cut in half. It didn't get fully cut because some drugs are not covered by the government plans, and private plans were still covering those drugs not eligible under the government. So what we're going to see is it's going to go back up to $244 million again in 2019, with inflation, etc. So it's unfortunate that those costs are coming back into the private sector, but they are, and so budget accordingly. We had a nice little savings, a nice little win for a couple of years there, but that is done now. But what could come onto the table now is national pharmacare. That's going to be a hot election issue, and it affects every one of us in this room, not only as Canadians, but as people in the benefits world. So, we as insurance companies have obviously a very vested interest in national pharmacare. And so we've done our lobbying, we've done our research. One of the things we've done is a survey of Canadians to find out, what do Canadians think about national pharmacare? And what they told us is that existing benefits are working quite well for the majority of Canadians. 86% of Canadians say they're satisfied with the benefits that their workplace provides them. 80% of them say it's affordable to me. The co-insurance or the deductibles that I have to pay are affordable to me. And 90% of Canadians say, if you have national pharmacare, I don't want to lose what I've got. I like what I've got, I can afford what I've got, And if the government wants to give me a drug plan, I don't want it to be worse than what I've got today. 3 out of 4 Canadians felt, why would the government pay for the drugs of people that already have coverage? If you're happy with your coverage and you can afford it and your employer is quite happy to provide the coverage, why should National Pharmacare kick in? It really should apply to people who don't have coverage. That sort of seems to make sense. And 94% of Canadians said, well, we certainly don't want you to increase our taxes. You know, Pharmacare might be okay for those people that need it, but don't raise my taxes. So we know that's what Canadians are thinking about National Pharmacare. And the reality is that we still do have a problem, and that is that 10% of Canadians really don't have access to Pharmacare coverage. They don't have an employer plan and they don't qualify for a government plan. And so that really seems to be the problem that needs to be solved. It's not to replace everybody's drug plan, but to find a way to deliver a drug plan to those 10% of Canadians that really need that help and that access. So there's different models and ways to do it. One of the ways that's been proposed, and it's sort of the thing that's been in the news the most, is a federally mandated system where the governments absorb private sector costs for everyone, including people that already have a drug plan. So the idea is no more private drug plan, we have a government national drug plan, and we will raise taxes by 1 or 2% in order to provide that to Canadians. Truth is, we wouldn't be able to have the same coverage. The only way to do that would be to reduce the coverage to keep it affordable and not cover, you know, think about the average private sector formulary or drug plan covers about 17,000 drugs. The average government formulary or drug plan covers about 5,000 drugs. So we would expect to see a loss in coverage with a federally mandated system, fewer drugs, higher taxes, and the federally mandated system says, and private drug plans can't cover those other drugs that are excluded on the government plan. That's the model that's been proposed. And the reason is because they need to negotiate better prices, and they will do that by moving volume. So as an example, so from 17,000 drugs down to 5,000 drugs. And the reason is all the drugs that aren't covered, they need the volume from those drugs to go on to the drugs that are covered so they can reduce the prices. Think about, you know, let's say there's 5 cholesterol drugs on the market, and each of the 5 has 20% market share. So 20% of Canadians take this one, 20% take that, till we get 100% of Canadians. Well, they might choose to cover one of those cholesterol drugs on the National Pharmacare plan. And the other 4, the market share would go to that one drug. So now 100% of Canadians take the one cholesterol drug instead of splitting it up amongst the 5 cholesterol drugs. That's how you negotiate a lower price. You move the market share, you increase the volume, and you get a better price. So that's why we would reduce the number of drugs that are covered, and we would increase taxes a little bit to fund that. And a lot of Canadians would lose a lot of coverage. An enhanced mixed system, which is certainly what our industry is proposing, would ensure that just those people who don't have coverage have access to coverage. So we just recently, just in the last few weeks, had the Trudeau government produce an interim report and budget for 2019. They have not been aggressive saying, you know, by 2020 we're moving to National Pharmacare, this federally mandated system, not yet, but it looks like they're starting the building blocks of what may become that. So they've announced that they want to create what's known as the Canadian Drug Agency, and that will be to negotiate collectively public and private drug benefit prices and coverage. They want to create an evidence-based national formulary. They have to invest and will invest in IT systems, and they want to come up with a strategy for high-cost diseases. You know, those $2 million a year drugs or even $500,000 a year drugs, if any of those claims hit any of your plans, you know, it would be catastrophic. And it would mean that, you know, you're sticking with your insurer forever, right? No other insurer is going to want to pick up your business when you've got a $500,000 recurring claim. So that's a real challenge for private plans, and I think that we're going to see some sort of a national public and private sector pooling mechanism to deal with those really catastrophically expensive drugs. At least certainly that's what our industry is hoping that we will see. So, you know, this is Justin Trudeau's government's proposed strategy. It's an election year. We're going to see a lot of models get talked about, and certainly it will be, I think, a hot election issue. So to summarize the discussion today, private drug plans face challenges to manage cost, and new strategies are important to ensure that drug plans are sustainable and that we have to evolve our strategies as the marketplace evolves. Most new drugs are not better than the older drugs that they replace, and it is imperative that the industry now moves to this model of assessing and reviewing new drugs before automatically adding them. And as an industry, we are pretty much there. I don't think there's any insurance company that automatically adds drugs just based on Health Canada any longer. Pharmacogenetics is in its infancy. Wider coverage will be available, though. We're seeing the insurance industry start to add pharmacogenetic testing as part of the benefits plan as an optional coverage product, and so you may start to see more of that availability coming. As I mentioned, a little bit of caution is advised on covering medical cannabis until we understand more. And national pharmacare will be a hot election issue, so please stay tuned. And with that, I do believe we have some time for some questions. Oh, it takes a moment for people to think. Yes?
I have a few things, so I'll try to pick one. The pharmacogenetics, there is a company called Personalized Prescribing.
Yes.
Yeah, and they, what they do is they send you the report that is easily understandable. Like they'll say specifically, these drugs could be a good possibility for you, these drugs are not, and this is the dosage. So you can hand it to your doctor and be like, I need this. Yeah.
So you're right. So that we're evolving where the providers of these pharmacogenetic tests are getting better information to give to your doctor.
Yeah.
We have to get doctors to accept it, though. You know, just because this is what we're finding in our pilot project. We give that pharmacist recommended letter in plain language, and the doctor goes, "Yeah, I'm still going to prescribe what I want to prescribe." So doctors have to come around to accepting and believing in these results. Then the other thing about pharmacogenetic testing, it's not just what the results of the test tell you, because understanding how you metabolize drugs and how to prescribe goes beyond just the test. And what I mean by that is the test will tell me how my liver DNA-based metabolizes drugs. But if I am a marathon runner versus a couch potato, that changes how I metabolize drugs. If I'm a baby versus a teenager versus a 60-year-old, that changes how I metabolize drugs. If I am of certain ethnic backgrounds, I have also differences in metabolizing drugs. If I'm a meat eater versus a vegetarian, that changes how I metabolize drugs. So it's the test as well as all those other things that have to come into making the right determination for the prescription. And that's where I say I don't think the average doctor's there just yet, but they'll get there.
I'll also add, Barb, you can add that to a benefit plan. I haven't had anybody do that, but you can add it for a cost per month. And the cost depends on how many drugs you want people to have access to as far as their DNA testing goes. If you don't add it and somebody wants it in your organization, it's $499, non-discounted. There are some times you can get discounts. So it's a one-time test. You pay $499. You have that report that you talk about, and you can do that. That will come down too, that costing.
Yeah, it will come down. You're right, as it becomes more, $500 is a little pricey right now, but I agree with you, the cost will come down.
What they do too is, because there was a HRPA, there was a webinar that was personalized prescribing talking about pharmacogenetics, and that was probably like a year ago that I saw that. But they talked about if companies put it into their drug plan, it would be a lot less than $500 because you would just pay per person as opposed to, right?
So it's so much per person per month kind of thing is how they would charge it.
Yeah, so it would be a lot less than $500 knowing that not everyone's going to use it.
It's about $5 a month per employee for the ones that cover everything.
Yeah.
I
think it's great.
The whole concept is fantastic.
I think the concept is fantastic, but I also think it's going to be really expensive. If you were to get a quote from an insurance company, it's not going to be inexpensive. And again, until the majority of physicians really understand how to prescribe and accept these tests, I would be cautious. I'm a very cautious person when it comes to adding things on benefit plans. So I would be cautious on adding pharmacogenetic testing, even if it is available. In a few years maybe, but it's still, I think, in its infancy.
Barb talks a lot about, you know, whether something's in its infancy, and that's why I appreciate listening to her, because she gives us what happens in the HR world, and especially in the benefits world. We're inundated with a lot of new ideas, and it comes at us every single week. And our job is to look at what is actually going to work for people. And we have to, you know, I always say I never want to be the beta. I want to see what's going on with that, because it can come back to bite you. And not saying necessarily that about pharmacogenetics, because I think that's so amazing what they can do. I say that about everything. And this is a huge industry, novel idea that, I mean, we fully support. And we do talk about it a lot. It's just, I can't say anything as to what the cost is ultimately going to be, or are you going to get cost savings or whatever. But if you listen to Personalized Prescribing, they're a very good company. Mm-hmm. But definitely they're going to be pro adding it. And they've got a great website if you want to see it. It's really good.
Yeah, they're Personalized Prescribing, Pill Check. There's a few different companies out there, and they're doing a great job of promoting. But again, when it's the provider doing the promoting, sometimes I like to just take a little step back. Similar to cannabis. If you talk to the cannabis producers, oh my gosh, cannabis will solve every problem in the world. You know, we've got to take a little step back and really look at more research and more evidence before we pay for things that may jeopardize the future sustainability of the plan. That's always my concern, is the corporation that we're all working for wants to exist 100 years from now, wants to continue to offer employee benefits in the future, and what we do today determines what might happen in 20 and 30 and 40 years from now.
I'd also say too, if you really want to cover cannabis, and you're worried about everything that you've said for all the right reasons, put in a healthcare spending account, because you don't have to worry about it. It's
eligible.
Spending account, you can spend every dollar on cannabis.
Yeah. You can spend your healthcare spending account money on pharmacogenetic testing as well. That's another way to do it, is to promote it through the healthcare spending account. Any other comments? Did you have it? Please feel free.
No, feel free.
Nobody else has got anything, so.
You were talking about that if there's like a legitimate company that does this testing of new drugs that come out, and we know that 85% of these drugs are not even beneficial or aren't better than cheaper options, can't benefit companies use that information and then not cover that 85%?
That's what we're doing. So that's what most of the insurance companies are now doing, is evaluating new drugs before we add them to plans. We're no longer saying, hey, if Health Canada covered it, approved it, it gets covered. Now we're evaluating, looking at the clinical evidence, and making a decision on whether that drug will be eligible. Yeah. We don't go back in time and take away things, you know, that have already been made eligible, but it's a more go-forward position. We're starting in about 2017. The majority of insurance companies said, no more Health Canada automation, you know, we're now going to evaluate drugs. And so that's what most of the industry is doing. So you're going to see a lot of new drugs are not going to be eligible under private sector drug plans. That didn't happen 5 years ago. We covered everything. So it's a big change.
Well, Barbara's going to be around afterwards, aren't you?
Did you have one more question?
Sorry. So with the testing, if new drugs come out, do you have to be retested for those new drugs? Or if you're diagnosed with a disease, do you need to be tested again? Or is that test good for?
Are you speaking of the pharmacogenetic test? The pharmacogenetic test, it should be for your lifetime because it's based on DNA, but that's where other things, your age changes, so age is a factor in how you metabolize, so you'd have to have a doctor knowledgeable enough to understand how age and diet and those other things will impact your DNA-based test over time, if that makes sense.
But is that just for sort of one condition and one treatment of that condition, or is that?
No, it's how it,
covers?
it's so there are many different areas on your liver where you metabolize drugs, and there CYP2, C19 is one, and CYP4532 is a different one. And so it's looking at your whole liver, and then different drugs go into those. Some drugs are on one enzyme, other drugs are on another enzyme. Grapefruit juice is another enzyme. That's often why you're told don't take grapefruit juice with certain medications, because it affects that enzyme, and then so does the drug, and that's why you can get a stronger reaction. So does that, I hope that, it's kind of technical, but I hope that helps.
So I missed one thing. We did not set up the seminar to receive accreditation, but we do have a note that we will give saying how many hours you've been here in the context of the seminar that you can give into your associations if you need CE credits. We'd be glad to do that. I guess I better use this mic. And there's, I think there's a form up there if you want some CE credits. Just sign that and we'll make sure that you get that. I want to acknowledge Great West Life. I'd like, does this work?
No, you need both of them.
Okay. This is just plain awkward. I want to acknowledge Great West Life for giving us access to Barb, and we've got great representation down there. So we've got Paul Ibbett, and we've got Joan, we've got Tammy, and is it Allie? Yes. Hi, Allie. Allie is new to us, but I know her parents very well, so it's great to have Allie with us. And we also have representation from RAM Insurance. So we have Dave Spear and Joan with us today. So if you've got any questions with regards to what's going on with RAM, they're here as well, and we're glad to have them. Just one more comment that I had, again, with pharmacogenics, it is available as a benefit. You can add it. You can do a one-time off. A couple of the carriers are offering discounts. For example, RBC Insurance. If you have RBC, you can get the pharmacogenic testing done for any of your employees at $299. So I think we're going to see a lot of movement there. And you don't have to pay for that. That's already comes with the RBC plan. But this is in its infancy. Lots of things are going to happen. It's all going to be good. If you ever get a chance to hear Dr. Kim, who is a personalized medicine specialist in London at LHSC, go and hear him. He's unbelievable in what's happening with personalized medicine, and he's a pioneer in the research that is being done now and was done in the future. The second thing I wanted to talk about was just a little bit more on that OHIP plus. So Barb, she said, you've got to go on your own benefit plan. And if you have deductibles or co-insurances or you have a cap on your drug plan or whatever have you, then you do not go back to OHIP plus. You go on Trillium. So if we've got somebody under 25 years old and they have a $10,000 drug, and let's supposing that only 70% of the drug is covered, then that person will be covered for $7,000. $3,000 comes out of pocket. It doesn't go to OHIP plus. Now, how does Trillium work? Because that person can go to Trillium. Trillium will pay darn near 100% of the drug if it's on the ODB formulary, which, as Barb said, represents about a third of what's on the regular formulary. So the person can go on to Trillium, but there is an annual deductible equal to 4% of family income. So if the child is dependent on their parents, and especially if they live in their house, then the parent's income is considered in regards to establishing family income for the purposes of the deductible. If the person under 25, though, is either A, the employee, or B, the dependent but not financially dependent, but of course then they can't be a dependent, so what the heck am I talking about? So we'll just go to the employee. Well, then it's just their income that is considered. So if you think about two spouses, and they each have an income of $50,000, that's $100,000, so the deductible is $4,000 a year. And it's done at $1,000 a quarter. So that's where it's happening with OHIP Plus. And all that news is just fairly recent. I mean, all of this stuff that Barb has been bringing out is all very recent information that's just probably come down, especially with regards to OHIP Plus and the results of it in the last month or two. So thank you again to Barb. So we're going to move over to a new topic, all in technology, and I'm so thrilled that we have Ravi Uppal here. Ravi is the brains and the technology and everything else behind an HR technological program called BOSSC, BOSSC. And it's all capitals, BOSSC. And it's probably the first one that I ever heard about. It's probably the most well-known base for HR programming. And what's happened with BOSSC is they've allowed it to be white-labeled. And so myself, as a broker, I have access to BOSSC-like software to offer anybody in this room or anywhere. I have the ability to offer BOSSC-like programs, but it may not be called BOSSC. So the one that I use, even though it's BOSSC, is called Everyday HR. So what's happened is that BOSSC has offered it to people for a price, groups of people. So I belong to an MGA. An MGA is the central clearinghouse where they have a lot of brokers that work through them. And so one of the benefits I get with working with an MGA is that I have access to all of these new products. And I don't have to pay the multi-thousands of dollars that it would normally cost me if I wanted sole access. So Group Force, which is the MGA that I work for or work with, I don't work for anybody except me, but they don't want me anyways. So Group Force has engaged BOSSC and white labeled it Everyday HR. So I'm so thrilled to have Ravi here talk about what's happening in HR from a technological perspective. And Ravi, come on up here, and we're glad to have you. Thank you so much for coming.
Well, thank you, everyone. Good morning. So, yeah, my name is Ravi Uppal. I'm SVP Sales and Marketing at BOSSC. So I'm not the technology behind it. I'm not the brains. I actually have no idea how it got built. I just know how to sell it. That's all I know. So BOSSC, we're a startup technology located just outside of Toronto in Oakville, Ontario. Been around for 5 years. Our team grew up in large HR outsourcing space. So if you think about Xerox, Aon, and all those organizations, they worked there. They said, hey, you know something, we can make something faster, better, cheaper, bring it down to small and medium businesses across Canada. And that's what we did. But the unique thing that we do is we distribute our solution through benefit advisors, just like Zavitz. So the reason we do that is they give us the distribution to everybody, but more importantly, the cost and the solution that gets down to you is a much, much cheaper cost. So currently we have about 48 partners across Canada that we distribute, 40 across Canada. And the unique thing is that we actually work with a lot of the carriers across Canada too. So our solution is connected to Great-West Life. We do work with RAM. We do work with Manulife. We're actually connected them to the back end. So what does that mean? Is that you can actually go on our system and actually, someone's having a life event. They want to change their benefits straight from the app. They can do it straight from the app and go. It'll let HR know and go straight to the carrier, and the carrier, it'll be updated in the carrier system. So instead of the way the things are being done right now, so that's one of the unique things that's unique about our solution. And everything we do is mobile first. So one of the first things a lot of the advisors we tell them to do is just go and show everybody the app. And they'll be like, oh, how do I get that? And that's the first thing we show. So we do have an employee portal, and we do have an HR admin portal that's available to the HR and to employees. So I'll quickly, I don't have too many slides, and I wasn't able to do a demo, but I have been showing people the app after, so I can actually go through the app after and show you some of the cool things that we're capable of doing. So in the last 3 years, we went around and asked a lot of small businesses, and what are some of the challenges you have? And disparate systems. No one uses the word disparate, but I guess it's on our slide. So I usually ask people, so what do you guys do? And they're like, oh, I got Ceridian. So what do you guys do with Ceridian ADP? You know, I use it for payroll. Okay, so what do you do for benefits? Oh, I actually go to this different site and I enter stuff over here. What do you do for time off? Oh, that's on a spreadsheet over here somewhat. So how do you guys do total rewards? Yeah. I got to add up something over here. I got to put it over here. So what is that? Is that some of the life that people are living, or sort of, kind of, in a different way? But if you do have a lot of the one system, you're probably paying a lot of money. So that's the real world, especially with small and medium businesses. Manual processes. You take it from one spreadsheet, you upload it into the other spreadsheet, you take it from another spreadsheet, you enter it somewhere else. A lot of errors potentially. A lot of the data is not clean, and this is going to cost you a lot of time and a lot of costs associated with that. What we've seen over the last year with everybody with their smartphones is ineffective employee communications. I was just talking to Jennifer in the back right there. She goes, we do our time and attendance on WhatsApp. I'm like, what? How does that, right? And how does that even make sense? Right? Right? And I was talking with, and then the people are like, well, you know, we get a lot of emails. There's a snowstorm. How many people had a snowstorm and they had no idea how to communicate with their employees? Are you guys coming into work today? And no one checked their phone. No one. Then next thing you know, people show up. You know, half our staff didn't show up today. Who's going to answer support calls today? So, especially when you're in sales, right? Someone wants to get a hold of you, and you're trying to close a deal. You get 1,000 emails, and that's email number 500. Oh, I didn't get that today. So that's some of the big challenges we see in effective employee communication. And finally, compliance, right? So compliance is huge out there. How do we had a company that said, I don't even know in my company who has first aid, who's certified for first aid. I don't even know if any of our truck drivers even have their licenses. And so these are, right? How do you not know this? So we don't know how to track. We don't know how to keep a track. We don't know. I can't communicate with them. I just got to keep it on a spreadsheet and it says Bob has their last analyst certification. So these are the things that we see out there. This costs you a lot of money probably. It costs you a lot of time. And then, you know, it doesn't allow a lot of the HR folks to actually do what they want to do, you know, make their company more fun and culture and all that stuff. Some of you guys have these problems. If you guys have none of these problems, I'll leave right now. And we're good. And you guys have had... Or worse? Do you have something to say? So the solution. So why everyday HR? The first of all is reducing the cost. The cost point that our providers, and you can go to them and ask for how much the price is that comes at, it really affects your bottom line. Just because of the way we distribute our product. And we're actually in the cloud. So we use Amazon Web Services. God love Amazon. They make everything so cheap for everybody. They do it for us too. So we can provide technology to people at a really cost-effective price. So anywhere from 30 to 70% cost. So when we're going against ADP, Ceridians, Payworks, Bamboo HRs of the world, you know, our cost really comes down and it will affect the bottom line of a lot of organizations. Increased efficiency. So everything we do, we try to bring it into one world. So we're bringing the carrier information. We'll work with payroll providers. We'll connect to anything and bring it to one app. So you can see your total rewards. You can see how much you clocked in. You can see your pay stub. You can see your vacation. You can actually do stuff right from there. You can do live chat with your HR. That's the first thing HR people turn off though, is the live chat, right? They're like, how the hell do I turn this thing off? I'm like, okay, Ed. Right? All I do is people bugging me every day on this thing, right? But over time, what happens is you can actually make it one way. So HR and management can communicate to their employees, right? Hey, guess what? Town hall meeting, quarterly review. Guess what? You know, the office is closed today. We have a snowstorm. What we've seen is you're going to be asked these questions regardless. Someone's going to email you. Someone's going to knock on your door. Someone's going to stop in your hallway. We're just trying to give a more efficient way for you to actually get a hold of your employees. Engaging employees. So everything we do is mobile, so you can talk on the app. You can actually send push notifications. You can actually get them to do stuff. So after a show, you can actually send a thing to the calendar on the person's app and say, I need you to update your emergency contact on your file. We have no idea. They can go in, oh, okay, do it right there and there. Oh, guess what? I need you to do your certain training or your certification, and can you attest that you actually did it? And then they go in and they do it. They can do it on a laptop too. But it updates your system right away. Check mark, this person's completed. Life continues instead of having to chase that person And finally, provide more value. So all we do is make this stuff better for our partners so they can provide it to you. So you can actually go to the employees and say, guess what? Now we can do health and wellness. We can keep track of, how much people have been sitting down all day, how many steps they've taken, engage in some sort of kind of health and wellness activities. So I won't get too technical because I'm not that too technical, but a lot of people will ask us privacy and where's the solution. So it sits in Amazon data centers in Canada, so none of the data actually crosses the border. And in the cloud is where all the data sits. So it's always communicating with each other. There's no double entry. Once you update it on the phone, it'll show up directly onto your systems right away, and you can see live changes and stuff. From there, there's 3 views into the system. There's the employee. I don't even know these slides. Oh, my team changed it on me. All right. The employee gets an app onto the system. The HR gets an admin portal. And the employees, just in case of some of the organizations, they don't allow apps and stuff, they actually allow, did I break some? I'm actually really loud anyway, so. Yeah.
How's that for technology?
Yeah.
We can't even put 2 mics into one.
And then some organizations don't allow their staff to have phones, or they're on a assembly line or whatever. We can actually do everything through the website, a website, so they can log in and do what they need from there. And on the back end, we're connected to the carriers. If we need to send information to another payroll provider, we can do so. And if we need to connect to any kind of third-party system. So depending on the size of the organization, the bigger you get, you may have a unique performance management system that you want us to speak to. We're capable of doing that also. Any questions on the technology? It's pretty, everybody uses Amazon, right? Finally, so the last slide here, I'll talk about the services that are offered. So the first thing I start off with is applicant tracking system Lite. And the reason we call it Lite is we're not going to connect to LinkedIn. We're not going to connect to Monster. We're not going to connect to Workopolis and bring it in. What we've done for small and medium businesses is if you're trying to hire someone, you can actually shoot them the app. They can log in with a temporary password, and they can communicate with you and say, hey, guess what, your interview's on Monday. Come on in and do the interview. And then you can send them feedback directly to them. Say, hey, it went well. Interview number 2 is coming up. And they come for interview number 2. And once they've done that, you can send them an offer letter. And from the app, they can accept the offer letter, and then you can shoot them an onboarding workflow. Great, welcome to the company. Fill in all this information for you. Whatever, first name, last name, bank, et cetera, et cetera, et cetera, et cetera. Now you've been onboarded, you can go enroll in your benefits because we're connected to the carriers. Go and change your benefits. Go add your dependents, your beneficiaries. Go and make any kind of changes that you want to from your benefits. And you know that it'll be sent to the carrier as long as we're connected to them. Payroll. So, this is probably the biggest pain point we see. A lot of organizations will tell us, something, I just went through ADP and Ceridian. It was a long payroll process. I don't want to change it. I just want to keep on with that existing payroll. No problem. Our system will just send this whatever data that the payroll provider you needs, the updates for benefits or deductions and stuff. But over time, we are a full payroll provider. So if you want us to do your payroll, we can do the payroll too. So we can do the deductions, T4s, ROEs. We can send the data to the CRA for remittances and stuff. I can't even see what that says. That says performance management? Oh, yes. We do that too. So performance, just a joke. Performance management, so we're not a full-blown performance management solution, but we give the ability for a lot of HR people to get surveys out to their employees, get feedback, say, hey, did you hit your quarterly numbers? Did you not hit your quarterly? How are you actually doing this? How are you actually doing this month or this week? The ability for HR to actually send a workflow straight to someone's app, and while they're on the, oh yeah, this is how I did today, yeah, and send it. It's really effective, and HR people are using it a lot. That's time and attendance and vacation, probably the number one thing people do, because how many people do their vacation off spreadsheets here?
Or not at all.
Or no vacation, awesome. Why we see a lot of people, how do you actually get your vacation? I just do a spreadsheet, I have no idea. How do you actually get people, they send me an email and they say I need 10 days off. Here you can actually set on the app, you can show them how much vacation they have because the system will automatically calculate it. And actually they can actually request vacation, send it to you or to your manager, and people just go in the system and approve it. It updates it to the app, and now they have their vacation. The other one is time and attendance, so keeping track of hours worked. So I was just talking to Jennifer right now. Through the system, you can clock in and clock out, right? So hey, I went in 9, and once they're done, I finished at 5. It'll automatically send a notification back to the admin portal and let people know, hey, this is how much hours so and so has worked. But if there's a time clock you have in your business, we have the ability to connect the time clocks to certain different ways and ingest that data into our system, update the hours accordingly, notify your manager, make changes, and then send that to payroll if need be.
Do you have your own mode too?
We don't do that, but there's a time clock company we do partner with. It's a real time connection that we're working on with them. We can let them know. We can send them over to you. You validate if it's good for your business or not. But if it does, our system will connect directly to them. Total rewards, probably a big one we see right now is the ability for HR staff to on the app and say, hey, this is what the value of it is. It's not just the salary I give you, it's the value of your benefits, it's the phone I pay for, the education, and updating the app right away, and they can see, hey, this is the value the company's providing for me. This is a big one we see with HR because I usually ask them, how do you guys do it? And they're like, we don't even do it. I don't even know how to get this data. I don't even know how to calculate it. I don't even know where it sits. It's a time-consuming process for them to be able to show that to their employees. Training administration. So we won't provide the content for training, but we'll give the ability to administer training. So what does that mean? Keeping track of, hey, I've done my first aid training, I've done my CPR training, I've done my trucking training, whatever kind of training it is, through the app, and someone can say, yes, I've completed my training, but the system will automatically notify them, say, hey, guess what, 6 months from now, you got to finish level 2 of your training for you to continue your job. If you don't, guess what, you can't go and do whatever the job is you need to do. The system will automatically update everyone that this person needs to complete their job, complete their training. And I don't even know what the last one is. Oh, our implementation team. Oh, okay, yes. So our implementation team, we work through our providers. We'll actually help you guys with the implementation. This is probably the biggest learning curve we've had over the last year is how do we work efficiently with our providers? Because at the end of the day, we want to educate them to do the implementation, but if we need to get involved to actually implement the solution, our team jumps on the call. We use a solution called Trello, if anybody heard of Trello. It has actually a live dashboard. People can see what the steps are, what's next, where the data needs to be uploaded in order for you to complete the solution. And that's everyday HR. The best part of it is actually when I show the solution, it actually looks pretty cool and I'll get excited. But if you guys want to catch me over there, I can actually show you the app and show you everything that I talked about. Any questions? I hope I sounded smart and techie there. Question? Yeah, sorry.
Can you run reports and customize reports?
Yeah, so any kind of data that sits in the system, you can customize your own reports. As long as it's a field attributed to it, you can drop down your own customized reports. It'll come with HR documents already populated. On the actual app, every document that gets associated with the employee, it's on the app. So where do I find the company book or the work ethics policy? It's directly on their app. They can go down, open it. They can actually do e-signature on the app too. So if you need them to sign something, they can just go like that, sign it, and it gets sent back to you. There's no limitations on the amount of data and space and stuff. And it's iOS, Android, and on the website is any kind of Chrome or any kind of web browser that you need to use.
So we'll all be on this. I mean, this is the future of HR. There is absolutely no question, and BOSSC is one of the pioneers. And it's moving fast. And by pioneer, I mean in the very beginning, when I first saw it, and then I saw some issues with regards to uploading and everything else, that's expected with new technology, but it keeps getting better and better and better. And so I do have access to BOSSC and HR First, and we do have the ability to offer it in sections and so on, and so I'll be speaking to everybody here about it, especially as we see certain things work. We like to try things out ourselves before we put it out on you. You don't like usually to be the test case. I know that. But this is the way it's all going to go. And it's all priced by the number of sections that you use, right? So I think he showed 9 sections, with the last one being implementation. So really 1 to 8. So the pricing changes based on the number of sections that you use. You don't have to use the payroll, you know, if you really love your own payroll system and so on. And so and it's usually priced per employee per month. So that will be very exciting to see what comes up. And I'm sure we haven't heard the end of Ravi and everything else that he does. So last but never least, we've got Meaghan Jansen with us here. And Meaghan, I met her, I forget how many years ago. It was the inaugural top 20 under 40 for London. And Meaghan was a recipient of that award. She is a Western grad for your master's program in kinesiology, health and wellness. I'm not quite sure what the actual degree is, but all in around there. And her husband started Wellness Solutions Network back, 15 years ago? 15 years ago. So what her and her husband have done is created a wellness program that is more in the employee's face than what a traditional EAP program is. So this is from my perspective when I work with EAP providers. I mean, it's great. Employees can go on to the website and they can look up whatever they need. They can phone the 800 number. There's lots of resources there. It's not just there if you're going through a crisis. It's there if you need some help finding a plumber or want to know about educational opportunities or daycare. It's there for everything. That's great. But it means you have to go to the website. And what I've discovered is that not a lot of people go to the website and not a lot of people will phone in. And so with Meaghan and her company, what happens is that you've got a lot of campaigns that you can bring to your employees. You can bring a lot of themes. You can even have somebody come in and your employees can sign up to receive some face-to-face help with maybe work issues or any of those types of things. They come to you. And so it becomes way more effective. And she's got a very simple but effective model with regards to increasing employee wellness. We started with her ourselves about, I think it was just January 1st. I'd only heard great things about her before that, and I can honestly say that everything I heard is really true. So with that, we're going to have Meaghan come up and talk to us about employee wellness solutions and how she structures her company. And thank you, Meaghan, so much for coming.
No pressure. I definitely won't take offense if you have to stand up over the next half hour, 20 minutes or so. Please do, because sitting too much is not great for our health. Well, thank you so much for the introduction. Barb, it's great co-presenting with you again. The last time we did so was in Toronto, I think in the fall. Ravi, you're entertaining. Thanks for your presentation. I hope I don't put anybody to sleep either. So today we're going to talk about my passion of bringing wellness to the workplace. And as Terry so eloquently introduced, it is a model that it has been really shown to engage employees. We do take on a preventative approach to wellness, very proactive, very much on-site, working with employees, not left on a portal somewhere. We do find that tactic isn't as effective in engaging employees. So when my husband and I started this business in 2013, we really focused in on, first of all, what the US were doing. Back then, it was EAP all the time. And yes, there's a space and a place for EAP, but as we know, they're very underutilized. People have to pick up that 800-pound phone to call for help. And so what the wellness strategy can do is, one, it can integrate very well with some of these reactive programs, but yet it can also be very effective in promoting health and wellness at the workplace. And so you can really have a program that is wellness focused in addition to a reactive program. And so both of them actually fit very nicely together. And so that's really what we'll be talking about today, is some of those main success criteria when it comes to wellness. So my first question is, the health of Canadians. So Barb obviously got into so many wonderful stats and information about the drug world, but are Canadians getting healthier? We've got the Nike shoes. We have the Guiding Stars program at the grocery stores. We have the pedometers, Fitbits, and everything else in our world. So why aren't we getting healthier? The reality is it becomes behavior change is not there. The novelty kind of wears off after a while, and so we have to think about sustainable change. And when it comes to personal health and wellness, we have to motivate people to want to make those changes. We just can't throw things at people and hope to God that they participate, which can all lead to frustration with this in this industry. It's like it just doesn't work. So we want to talk about ways in which it can work. So how many of you in this room do offer or have, one, a wellness program already, or two, somebody in your work site that is excited about wellness? Let's start with the first question. How many of you have a wellness strategy? Not too many. How many of you have an interest in having wellness in your organization at some level? Okay. Those of you with wellness, do the same people participate all the time? That's one of those frustrations. Is, well, Meaghan, yeah, it doesn't work, but when it does, it's the same Boston Marathon people that participate, right? So it's kind of like looking at that continuum or spectrum of our population, where I'll talk about a little bit more so coming up, but you have the Boston Marathoners on this side, then you have the people that may not have seen a doctor in 10 years on this side, then you have everybody in between. So effective wellness strategies, I'm getting rid of the word program. It's not a program. Program is too much here today, gone tomorrow. It's a strategy. And so if a strategic approach is adopted, our engagement rates increase. And we have some examples of that. So in terms of some of the data and some of the looking pertaining to claims cost distribution, we know that disease cost prevention saves. This has been something that's been around for a long time. Nico Pronk, I do international speaking through the International Association for Worksite Health Promotion. Nico Pronk is one of my colleagues and actually a mentor of mine in this space. He's a researcher. He looks at evaluating wellness strategy. And he presented this particular slide at a most recent American College of Sports Medicine conference. And he talked about how on this slide, you'll see here on the healthier low risk, I wonder if there's a little, there we go. Healthy risk, at risk, high risk, and early symptoms and active disease, just to orient you to this slide. You see here the bell curve. If we were to run a health risk assessment with your organization, we were to identify some of those high-risk employees and the low-risk employees, your bell curve would look exactly like this, whereby 20% of your employees generate 80% of your costs. These are the employees that have claimed or on sick time or on disability that are expensive. The other employees, 80% of your employees from healthy right up to high risk, only generate 20% of your cost. So what's the moral of this story? We don't want to forget about those 20% of those employees that are claiming and that are very, very high risk and into early or active disease. We want to really identify programs that keep the healthy healthy. Not just the Boston Marathoners, though. Those that are very still high risk and might not know what they don't know yet. We want to focus on that 80% of a population. So organizations recognize this. They see their costs. They talk to people like Barb. They talk to people like Terry. Their costs are increasing. You've got an aging workforce. People aren't happy, etc. They tried adding healthy snacks to the office vending machine, but all that rotting fruit made the candy bars taste bad. So people kind of grasp for, oh my gosh, what do we do? We're kind of in reactive mode. We've seen something happen. We have to do something, so let's put in a healthy vending machine, because that's a wellness program. I have to tell you, I presented in Halifax 10 years ago and asked this question. How many of you have a wellness program? And 2 hands popped up. And this gentleman was so excited, he stood up, and I said, what do you do, sir? He says, we sponsor our softball team. And he was so excited. That was his definition of wellness. And so when we look at different types of programs and definitions, there's a lot of them. Obviously, this becomes a frustration. Well, we do it. We check mark. We do wellness. We have this. We have, a speaker come in every now and again. We do a health fair the odd time. We might do this. We might do that. But it just doesn't seem to work. So it can definitely pose problems. Whether you have speakers come in, sponsor a team sport, do a company picnic, bring in a golf tournament, you've got EAP, these are all really great program components, but this is all they are on their own. We have to tie this together to optimize the strategy. It's no longer a broad stroke approach to wellness. One thing doesn't work for everybody. That's the issue. We have to think more specifically on what's going to make the most sense. Good wellness programs do something. Something is better than nothing at the end of the day when we're promoting prevention, health promotion, being proactive with our employees. The challenge is, and another frustration in this industry, is we'll throw everybody in the same box and we'll throw a heart disease speaker at them and everyone's going to go, or we're going to do a Fitbit challenge and oh my gosh, we're going to have everybody participate, yet they don't, and then you decide it doesn't work. So this is the challenge, is now wellness is important. We know preventatively it's important for all of the reactive costs we have. So what can we do to really optimize our efforts? There are 3 success criteria to optimizing engagement. The first one, and I've been preaching this for 15 years, it's supportive leadership. If you do not have supportive leadership, it's like climbing Mount Everest. Now this goes for not just a wellness strategy, it goes for any strategy, as you know. If you don't have support, it's not going to go anywhere. So supportive leaders are critical. One of the biggest challenges in wellness, bringing wellness programs and wellness strategies to the worksite, is communication. After 2 years, you're going to have an employee come to you and say, what? We have a wellness program? It does happen, trust me. So when we're talking about leadership support, it's the communication that definitely has to be there. And just to sort of depict the hierarchy of an organization, not to indicate that all are like this, but we have the C-suite executives, C-suite leaders, communicating to the middle managers communicating to frontline staff in terms of different things. And a perfect example of this, and then we've got the C-suite communicating with frontline staff. One of our local organizations here in London, perfect example of this, we run a health fair every year. And the CEO, every year, writes a memo to all managers, all frontline staff, giving them an extra 1 hour off at lunch hour to come to the health fair. So not only do they get their lunch, they also get an extra hour to visit the vendors at the health fair. This memo is expected, and it comes directly from the CEO. So that is an example of overt support, where you want your people to partake and participate and engage in the program. Within these 3 levels, what level do you think is the most challenging to engage?
Senior leadership?
No. No. Who said middle managers? Oh dear. It's a stress ball. I don't want to stress you out, Cynthia. Middle managers are the toughest group for wellness. And I'm going to tell you why. Yeah, it's fine and dandy to get a directive from C-suite, but I'm too busy to think about anything else. And I don't even have the time to talk to my frontline staff about this new initiative or this program because my deadlines, my projects, etc. They just don't have the time. This is where I think, even in our world, I think some further look and how to engage these supervisors and middle managers is critical to really any success. So that's really an important part. Those of you with wellness programs, how many of you have a wellness committee? Okay. One of the nuggets or takeaways that I love to, when I'm presenting, I always suggest if there's one thing you can think of to put in your back pocket when you leave here, you go back to your work site to think about implementing, is there a small group of people that is a cross-section of your organization that you could enlist the assistance with in helping you do this? We are inundated with resources, materials, content, and we do need the help to do it. Certainly not on HR's shoulders, but can we spread out the workload a little bit? So if we can start to think about spreading the message, having a group of people help you communicate wellness, we do find that this wellness champion or wellness champion network can be very effective to help you do that. So that's really part and parcel the leadership support piece. Now the second success criteria with engagement, and I talked about it a little bit earlier, is taking our program components that we want to do through EAP, through your wellness team or your wellness champion network, through some of the different content maybe your carriers provide for you, but we tie it together. So if we can tie it together, there's some really great support in seeing how this tying together the strategic approach can be helpful for culture. So there's lots of interesting things in the space. Obviously, communications, knowing your space. One of the other challenges we find in this space is, well, we have 4 or 5 different offices in 4 or 5 different cities. How can we engage everybody at the same time? Obviously, there needs to be some logistical pieces put into play, but really looking at how we can ensure it's as inclusive as possible is important, without it sitting on a portal somewhere because your people will not go to that portal. So we have to think of different ways to engage people. We have to get back to the people. Yes, Ravi has the greatest app in the world, but we have to get back to the people, specifically with this particular, can you tell I'm a passionate person about this? I am. But the integration piece is critical, and your wellness team can help build your wellness toolbox. We have resources in our community that are free. We can enlist the help of people to make your workplace great by supporting your people. And we can do that in so many different ways. And building a wellness toolbox of people your people know is definitely helpful. One of the, now you won't be able to necessarily read this slide, but I want to show you what a strategic plan looks like. So we take in these components and we make sense of it all. This particular organization ran a health risk assessment. Questionnaire, assess the situation, identify the top 5 health risks of that organization. It's a great starting point to know what to do. So this particular group, I don't know, this must be on a timer, I'm talking too slowly, I guess, was on weight management, improved fitness, nutrition, heart health, and stress. Sorry, I don't know why this is going. We'll just pretend that that didn't happen. So what I'll do is I'll orient you to this slide. Down the left-hand side are all of the toolbox components: newsletters, posters, individual challenges, health coaching, exercise classes, etc. So the toolbox was quite deep. Now what we then did is across the top you'll see January to June, and then we'd had the other one from July to December. At a full year glance, you can see how we layer on wellness in different ways, and there's a reason why we do that. We understand how adults learn. It's the psychology of behavior change. One poster, one speaker, one Fitbit challenge is not going to be successful. How do we integrate all of these different ways of doing wellness, ensuring that we're inclusive from the people that have not seen a doctor to the Boston Marathoners, to ensure that we're including as many people as possible? So what we did is we started to look at what types of programs made the most sense. So for the first 3 months, we focused on healthy weights. We layered on one-on-one health coaching. We had some lunch and learn, some speakers. We had a healthy potluck at each of the offices. We had a challenge. We had newsletters. We had some displays, healthy weights for you. We had all sorts of different things, healthy snacking. We had the health coaches walking around. We provided some various touch points. The objective of any wellness event or wellness activity is never to get 100% of your people participating. It's never going to happen. Versus with all of the things one can run in a worksite wellness strategy, can we get as close to 100% participation or engagement in any one thing? Can Cynthia read a newsletter? Can Sherry participate in a yoga class? Can Terry do a health coaching session? Everybody ideally is engaging themselves in at least one thing, and that's really what we're trying to do. The fun things, food's a great bribe with wellness, so potlucks, sharing recipes, having different things to try, definitely engages people. The second quarter, we focused on exercise, specifically walking. So we had, it's free. You go on Google Maps. We had walking routes. We plugged in the address for each of the offices, and it gave us 1 kilometer, 2 kilometer, 3 kilometer, 4 kilometer routes from that building. And we printed them, and we had people, Pat Schmidt's nodding her head at Harrison Pensa, one of our very first clients 15 years ago. We're still with them. That was one of the things we did. We printed off posters and maps, and people got out there and started walking from that particular address. So it gives us an opportunity to use some really great things that are accessible for us. We did some challenges, some movement exercises, etc. Desk stretches, step checks. So this gives you an idea as to what a successful wellness strategy looks like. This is what it takes to engage your people. Now, some of you might be thinking, oh my gosh, Meaghan, there's no way in God's green earth I'll be able to kind of figure all this out. Not to fret. There are different things that can be done more simply, but the objective of this slide is really to showcase how the layers need to be there. We just can't expect a speaker to engage an audience. There has to be other things in place because not everyone's interested in listening to a speaker. Not everyone's interested in going to a health coaching session or attending a yoga class. There might be other things and different ways in which adults need to engage and learn, and these are different touch points that provide that particular strategy. The third success criteria really goes down to promotion of behavior change. This entire model is focused on helping people change behavior for the long haul. It's not a weight loss biggest loser challenge. We don't even promote those because it's too short, quick fix. We live in such an immediate society where we need to see changes right away. And this is where we start to see some of that sustainability model of actually helping people change behavior so they're not claiming with cholesterol medication or they're not finding themselves in the hospital because of high blood pressure or cardiovascular disease. So how can we at the work site, we spend, I don't even know what the stat is, hours upon hours during the day at work, how can we have our work site promote health? And these are, again, different ways in which we can do that. Number one is repetition. You saw my layering on approach of that strategy. The reason why we do that is we have to see the information more than once. Some of our examples of this, one of the organizations in which we serve love bathroom posters. I know that sounds kind of weird, but you've got a captive audience in the bathrooms, no kidding. But now we actually did provide recipes. They were taken, so we didn't do that anymore. Mind you, they were taken, so that's a good thing. But repetition in people's faces. If you have media boards, some organizations have screens or TV screens kind of in and around the organization. That's also beneficial. Bite-sized messages are meaningful to the individual. This is all that adult psychology of learning new things. We need to get down to grade 4 level. As funny as that sounds, we definitely have to look at that. This is the Prochaska model of readiness to change. So the readiness to change model essentially takes a look at if someone wants to change a behavior, quit smoking, lose some weight, go to the gym, eat better, there is an indicator of if you're actually ready to make that change or not. Now, not everybody is ready to make big changes with their own personal health and wellness. Some people just have it, where, yeah, I'm going to get walking every day, I'm going to go do this, I'm going to go do that. You're intrinsically motivated to make changes. Not everybody is. People who exercise regularly hurt if they don't exercise. People who don't exercise hurt when they try to exercise. So we're kind of damned if we do, and we're damned if we don't, really. But this gives you a quick look. We have 5 levels or 5 stages of change: pre-contemplation, contemplation, preparation, action, and maintenance. 5 levels. So let me take a smoker. Hopefully not too many people smoke anymore, but we'll take one. The pre-contemplator is a smoker, not interested in quitting, don't want to hear about quitting. I like my cigarettes. Don't tell me I can't smoke. I love to smoke. They're not ready to listen to anything different. Pre-contemplator. The contemplative smoker is thinking about change. Yeah, I've got a grandson coming along. I'm kind of thinking about it. It's something I know that I should be doing, but I'm thinking about it. The preparation phase of that smoker is, grandson's here. I want to quit. I'm looking at a quit date. I'm doing some of those preparation things in order to make this a reality for myself. Action, quit date comes around, they've quit smoking. Maintenance is they've been smoke-free for 6 months. So these 5 stages of change happen for people who are afraid or want to go to the gym, but they don't really want to. They don't really know how to go to the gym. Be there and be comfortable. People who want to eat better, people who want to drink more water, people who want to de-stress a bit easier. So these are, again, different stages of change for any lifestyle behavior. Most organizations mistakenly spend most of their money in the action maintenance phase. An example, gym memberships. I love gym memberships, but unfortunately, they aren't as used. It's a nice thing to do, but they're not engaging. They're not getting as much bang for their buck with people wanting to use the gym. People have to get in shape in order to use the gym. That's what people are saying. They are afraid to go to the gym. So this is an example of where most organizations spend their money. My first example of keeping the healthy is the truth, but we're really focusing in. We want to see the most area for positive change with these people that need a little bit of nudge, need a little bit of support in making some of these healthy changes. So this is where we start to see the most impact and change for people actually making sustainable lifestyle choices, healthier ones. So that's really what we're wanting to accomplish with this particular slide and with this particular model. So, what types of programs can one use and implement should they want to make some sustainable lifestyle changes? Any great wellness strategy is going to include different tools, resources, on-site, in-your-face touch points, and archivable content for all these 5 levels of change. The pre-contemplators are not necessarily going to sign up for a health coaching session or go buy a new yoga outfit for the class. They're not ready. But what can we do to ensure that we're nudging them along in the right direction? One of the ways in which we want to do that is through visual cues. Any great wellness strategy is going to have layers of wellness materials and content organized to make sure that there's a need and make sure there's enough visual cues for those individuals. Things like wellness newsletters. If you have a corporate newsletter that you submit every quarter or every 6 months or every so often, can you have a wellness section on that particular corporate newsletter to show that support? Posters, resources, health fairs, very visual. Seeing your wellness champions walk around with healthy snacks. Maybe have a smoothie bar set up in your kitchen. Get a blender. They're $50 at Walmart. Bring it into the kitchen with a few different fruits and veg in your freezers. These are visual things that these people are ideally it would be their first hook into recognizing that, oh, I could try that or I could do that. So these are different visual cues that are important for those pre-contemplators and those who are kind of on the fence of making some changes. Those in the preparation or action phases, these are the people that like challenges. They're kind of already past that, I know I've got to be healthier, I know I want to kind of make some changes. Now they need some of this content competition, trying different things to try to make some of these changes. So these would be the people that would sign up for your heart health speaker or your dietitian coming in to present on healthy eating. They might participate in your challenge. These are some examples. This is a healthy lifestyle poker, spring Scrabble, all different healthy things they do healthy tasks for points. It's a point race. So there's just different things that these particular examples of programming can be very beneficial for those people who are thinking about making a change. Then finally, maintenance, they need to have fun. These are the people that would sign up for these different fun things that if your organization logistically can provide. These are some examples of photos. Some of them are London-based, so you might recognize some people. We had a staycation day at London Hydro. This is Jeff Harrison, if anyone knows the health and safety, so that's him. So he's doing the limbo. We had a staycation day. People, go away from the Caribbean, and I was just in Cuba, so I can't really say that. But we brought in the little baby pools and filled them with some water and brought some lawn chairs. And so anyway, it was we had a fun day at the work site. Some smoothie days. This one down here, right here, is human foosball. So they had a room about this big. Great idea, Terry, for maybe Zavitz, is doing some adult recess. So at lunchtime, they had some fun things happen. So that was at a local organization. Potlucks, we had an Olympics day. This one is around right here, is a couple people doing blindfolded lemonades. They had to make lemonade blindfolded. So again, might sound ridiculous to some of us in this room, but these are the type of people that really like to get into things. And so those people who do need a little bit of fun, it can be beneficial for those types of people as well. So before I go on to the last little bit here, there is a reason why we want to bring in wellness in these different ways. Everything from as simple as a visual cue to as integrated as adult recess program. There's differences among all of these, but definitely together they can make a big impact. So in our world, return on investment has been sort of the bane of our industry for a long time. And several examples of ROI through years and years of data research and looking at really what makes the most impact on return. It definitely comes down to following a strategic approach. And without getting into too many examples of that, there is definitely a reason why we want to definitely look at some of those returns, because that's important, obviously. Has anyone heard of value on investment as a new-ish a kind of word, a new-ish term, and also value on caring? It sounds a little fluffy, I get, but it does definitely bode the explanation of what are other things we can measure. Culture is a big one. We have some really great Canadian researchers doing some interesting things on culture. Value on investment's a big piece, and we have to be definitely aware of that. Even as something as looking at goals or objectives of Healthy Workplace. There's several. Benefits Canada has a wonderful platform for recognizing healthy workplace. Excellence Canada is another one. So are there different ways in which, as a return of all of the work that we do in this space, can we be recognized for being healthy as well? So that is, again, just something to consider when we're really looking at that particular example. Another way I like to explain the ROI VOI is January 1st rolls around, we get on the scale, and we're like, oh dear, and then we get off the scale and we throw it away, and then the next day we step on the scale and oh dear, and then we get off the scale and we throw it away, and we do that every day or so. We get frustrated because that darn number is not going to move, right? So if we only focused on doing the right things, moving a bit more, choosing a bit more wisely, drinking a bit more water, and sleeping better, those results eventually happen. So it's the exact same thing with our wellness strategies. Do the right things, the returns will be there. And so that is really, it comes down to as simple as that. We have to focus on doing the right things in order to see some of those changes along the way and the sustainable approach to wellness. Healthy people, healthy culture, healthy returns. This is really, again, I think it really sums up the discussion today on looking at some of those main areas of engagement and main areas of success criteria when we're implementing a wellness strategy. One of the other things that I do, some of you might be following us on our social media handles, is every Wellness Wednesday I'm interviewing, and I'd like to interview Barb and anybody else who'd like to sit with me for 10 minutes. We record an interview and we talk about the industry. So we have lots of different guests that I have interviewed over the last little while. We have several coming up. This just gives you a snapshot of some of the different professionals that I've spent a few minutes with. We record them and we post them. We talk about the industry, best practices, strategies, return on investment, optimizing engagement, what's going on in this industry, what's coming up, what are the challenges, lots of different things. So HR professionals, employee benefits specialists, insurers, the full gamut of people. But it's a great way to educate and continue this conversation. I'm on a mission, as I say in every one of my interviews. I'm on a mission to continue this conversation of elevating the profile of employee wellness. And by listening to some of these professionals, it's a really great way to educate yourself. So we're on social media, Instagram, Facebook, Twitter, LinkedIn. I don't know a whole lot about technology either, but it's there. So definitely, they're only 10 minutes in length. Some of them are a little bit more, but definitely keep an eye. And I've got international people too, because I do lots of work internationally, so it gives me some great opportunity to talk about wellness. Okay, it's my birthday yesterday. So I'm spending my birthday, well, I was going to say today, but then I would be lying, and I don't feel good about lying. So one of the things that I am pretty excited about, and I got permission from Trudy and Terry, is I want to give away a wellness strategy. It's value of $2,200. It's entirely up to you if you want to take us up on it. It's completely free for 12 months. So if you would like one of these, put your hand up. Someone put their hand up. Okay. My birthday is April 16th. Who of you has your birthday as closer to mine? Any April babies? Anybody close to April 16th? February. May? August? Well, May it is. So let me tell you what you get. So this is their promotional coupon. It includes unlimited employees, doesn't matter how many employees you have. We start with a wellness strategy discussion. So we talk about how to optimize the strategy. We learn what you have for programs, how to integrate wellness within your strategy. Monthly wellness digital newsletters that can be easily switched to PDF, to print, post, archive. Don't stick it on a portal. Individual wellness challenges every month. We take your 12 months, we divide it into 3 health campaigns. We mail you posters to your door. We provide email campaigns, content for this particular campaigns. We have 3 family wellness webinars. We do 3 a year. This year we did a seasonal affective disorder in February. We're doing mindfulness in May, pretty excited, and TBA for the fall. You also get an individual health risk assessment for all of your employees, 10 minutes to do. Each individual gets a personalized report. At the end of the campaign, you as an employer will get a corporate trend report to give you more insight of what's going on with the organization, and for $0 a month for the first 12 months. So this is for you. So because it's my birthday yesterday, I'm going to pull an Oprah, and everyone gets one. So everybody who has a birthday and everybody who wants wellness for the first year, I do have coupons, so I'm pretty excited about this. So if you are interested in starting this properly, with a strategy, a foundation, with content, it takes the workload off of you to try and figure out what to do next, come see me and we'll get you your coupon. All you've got to do is email. There's an email here at the bottom, so email me and we'll get you set up. Okay? I think that's all I have. That's all I have.
Thank you for that, Meaghan. 'cause
You're welcome.
That is a fantastic way to find out about